Welcome everybody to the April 2026 meeting or session of the Community Board, Queens Community Board Two's Health and Human Services and Education and Unhoused and Shelter Committee. So tonight, among our presenters, we have Jordan Rosenthal, who is going to present on the Be Heard pilot program. We got a sneak preview maybe about 2 months ago, and now we get to hear the full presentation. So thank you, Jordan, for coming back.
No problem. Thanks for having me.
You're very welcome.
Um, Let me just, okay. So, my name is Jordan Rosenthal, and I am the Director of Advocacy at a supportive housing nonprofit called Community Access, but I'm also the lead organizer for a coalition called CCIT NYC, which stands for Correct Crisis Intervention Today, New York City. And I'm here to talk to today to talk about not only CCIT and the work that we do, but specifically our advocacy around the Be Heard program, which is an acronym that stands for the Behavioral Health Emergency Assistance Response Division. And I'm going to get more into that later. Um, so CCIT is a coalition of peers, which are people with lived mental health experience, nonprofits, and community members who are working to transform how the city responds to mental health crisis calls. And we've been around for way too long. We had a birthday party last year for our coalition, and people were asking, how old are we? And I said, we're too old for a coalition. We shouldn't be around anymore. Um, but the reason we're even called CCIT is because originally we advocated for CIT training, which is when police officers or corrections officers meet with someone with lived experience and they do this one-on-one kind of education about like what crisis intervention looks like and understanding from that person's perspective. And we found that wasn't really working or really that effective at all, which is why we added the additional C, as in correct crisis intervention today. So, what does correct crisis actually look like? So that's where our Peers Not Police campaign comes in, which is really about utilizing peers, like which I said are people with their own mental health experiences, and creating this system, which I'm going to go into more so on the next slide, that's modeled after programs like Cahoots in Oregon, the STAR program in Denver, Colorado, or the Gerstein Center in Toronto, Canada. And these are just some pictures from a rally that we had on City Hall. And the top one is a bunch of our steering committee members. And then the bottom, just with the signs.
I'm sorry,
Um,
is that Jamani Williams?
yes,
Is-
Jumani he's not our not on the steering committee. He's just a very good supporter of ours and has been
Okay,
a supporter of ours for quite a long time.
okay,
Good clarity purpose. Thank you for
okay, all right.
that. Um, So, what is the CCIT proposal? We would want a non-police mental health crisis response system that has small teams of two, which where you'd have a peer who would be trained as a crisis counselor and an EMT. And this program would operate citywide and 24/7. And the peer is like the secret sauce, right? Because it's the person has gone through maybe not that exact experience, but experiences like that themselves. So they have insight that a practitioner might not have. Um, our vision utilizes 988, which is the three-digit crisis hotline, rather than police run 911 as a primary contact method. So right now, basically what happens is when calls come in through the CAD system or through 911, they, go through an algorithm that basically says like what type of response can be sent. And one of our pillars or what we kind of argue is that it's not that easy to just leave it up to an algorithm, especially when the person who is like the 911 operator isn't trained in mental health and specifically like sussing out whether or not something is actually a crisis. And I'll kind of get into that a little bit more later. Um, So, but we would want interoperability between all three-digit numbers. So basically, if a call came into 311, it could be transferred to 988 or 911 and vice versa. And there would be like coordination between these three systems. And there would also be a coordinated response system for prevention alternatives to hospitalization and, supports afterwards. And the alternatives to hospitalization are places like crisis stabilization centers, which are places where you can go up to 24 hours and kind of like relax and figure out what your next steps are. Or a crisis respite center, which is an alternative to the psych ward where you can stay up to 28 days. And some have like providers, like medical providers on site. Not all of them do, but they're, a place where you can also kind of have a reprieve and figure out what your next steps are. So that's kind of an overview of what the CCIT proposal is. But what is the current landscape? So we have Be Heard, and Be Heard uses EMTs and a licensed social worker. They operate 7 days a week, only 16 hours a day in select geographic areas, with only 9 teams during the first, like the day shift, and 9 teams during like the night shift. Um, if you have a crisis call that comes in, not during these times, you will be met with a police response. If you have a call that comes in that's not in one of these geographic areas, you will have a police response. I actually misspoke last time. The 108 and the other parts of Community Board 2 actually do have Be Heard in the encatchment district. It's just the program is so sparse that it's so like even though places are covered, it's like, oh, like does it even come out there, right? Like type of thing. Um,
How are they
and
determining the catchment area? Like, what's the basis for selecting a particular
so
geographic area?
it's been a pilot for several years and they haven't really made it fully citywide. And there's no exact rhyme or reason. So for instance, I don't like the term EDP, but that's the, term that's used for someone. And the area with the highest EDP calls is actually like Times Square, and Midtown does not have Be Heard.
Hmm.
Like it does not operate there. It actually, I think it's like 110th Street and up is kind of the border. It used to be like 125th. Um, but yeah, I think personally, but this is conjecture, um, that part of the reason like Community Board 2 in our area was included in this pilot when there's been expansion of the geographic bounds is that they were trying to connect the boroughs. And when you look at a map, and unfortunately they took the map down from the website when I was working on this PowerPoint, because that's something I'll get to later too about the inconsistent data. Um, is it would be like a throughway of like actually instead of being piecemeal, like you could see like the blue lines kind of connecting, if that
Hmm.
made sense. So it
Hmm.
was like a connector piece, but I don't know for certain. But the overall goals of the program are to route 911 mental health calls to be heard when appropriate, increase connection to community-based care, reduce unnecessary transports to hospital, and reduce unnecessary use of police resources. It's a collaborative program run by all of these different agencies, but as Mayor Adams was on his way out, and because there's been such a shortage of EMTs, he actually made it where the program primarily operates through health and hospitals, which I there's mixed feelings about, right? Like health and hospitals is more peer friendly. They have peers in their programs, it's a public institution, but it also seems a little counterintuitive if it is a public-private hospital system and they have a benefit of people bringing people in, and one of the goals is reduce unnecessary transport to hospital. So it could be argued either way. I one thing though that is apparent that it becomes a problem later on is that there's too many cooks in the kitchen. Um, so really quickly, just because I know that for time and stuff, and someone else is going, there's a bunch of slides. What does Be Heard response entail? It basically is these team of two coming to you and doing an assessment, some crisis counseling, de-escalation on scene, making sure that the person is okay. They might do some basic medical care, and then assess what the next steps are. Do they need to go to the psych ward? Do they need to go to a stabilization center? Is there a respite bed available, right? Like kind of just figuring out where that person, how they can be best served and what those next steps are. And then how are teams dispatched? So they're dispatched through 911, but you cannot request to be heard. So if any of us saw someone having a mental health crisis and called and said, I want a be heard response, that would not be taken into account. It might end up being a be heard response, but the fact that we are requesting one is not a factor that is taken into consideration. So that's just a very interesting point to kind of put out there. Um, so 911 operators and EMS are trained to triage the calls, and they're, based on is a team available, how soon will they get there, kind of like all these different factors. And we're going to go into data later that shows you like how few people actually end up getting a response. But one of the things that I find really interesting is that at an oversight hearing that was held in almost 2 years ago, they said that the factors that they assess for whether or not sending be heard are violence, weapons, or suicidal behavior. And if none are involved, then the call can be typically routed to be heard. Violence kind of makes sense, or not makes sense, but we always say that for like non-violent situations, like, be heard should always go there. Where it starts getting really tricky is like, if someone has a knife, is it a butter knife? Is it a steak knife? Like, right? Like what, there's different degrees. Um, and in a lot of situations, also, we have seen situations where a call doesn't come in as violent or a weapon, but because police are there, the person or the situation gets escalated and a weapon might be picked up because the person has lots of feelings and the situation is being escalated. So we want to avoid that, right? But the piece here that I find really odd is the suicidal behavior because it's supposed to be a mental health crisis response system. So it's very odd just how this program kind of works or is limited in its ability.
So who are they thinking would respond to the suicidal behavior situations? The police as well?
Yeah, and that it
Okay.
would only be police.
Okay.
And like they're not down for co-response. And I will be honest, a lot of people that I work with are opposed to co-response. And that would be because, even if the police officer wasn't trying to instigate or antagonize, them just being there inherently kind of escalates the situation. Or even if they're not there, let's say even if they're parked down the street, maybe seeing sirens or like the lights and hearing something could escalate the situation. And that's really what we're trying to avoid. And not always, but depending on the situation, people may have had really negative experiences with police or institutions previously. So they're not going to be very open to seeing another kind of like armed or uniformed person kind of telling them what to do. And the idea behind Be Heard was kind of to have this like bridge of a non-police mental health crisis response system. But the problem is that it doesn't use all best practices. Um, so really I'm about to just go into some data that shows you like all like how problematic it is. Um, this right here, this chart is the total 911 mental health calls in pilot areas during pilot hours. So the blue bars are all of the calls that came in during the pilot areas. And you have to remember that the pilot areas are also expanded over time. The line through it on the bottom is just calls eligible, not even like calls responded to, just calls eligible. So less than half of mental health calls aren't even like can get a response. It's very few and far between. So Be Heard has a data problem, and partially because they haven't wanted to show that it's been such a cluster, quite honestly. So there hasn't been consistency about the data. And one of the things that we've been advocating for are more transparency and more consistent data briefs. And key variables we want, but aren't, an exhaustive list are like, what is the average response time? What are the total number of mental health calls in the pilot area? What is the total number of calls eligible that got a response? What were the number of calls that you made contact? What are the number of calls that received a mental health assessment? What were the outcomes? Um, and all of this is inconsistent throughout the program's existence. I think it's much more promising now in the Mamdani administration, but we're early, and this is, when they talk about the Office of Community Safety and stuff, this is a program that's going to fall into the Office of Community Safety. So just to give more data examples, the comptroller did an audit and they found basically 60% of calls that came in were ineligible for Be Heard. And that could be for lots of different reasons. It says right there. And over 14,000 calls were determined to be eligible for Be Heard, but did not receive a response because they were during overnight hours when the pilot does not operate. And then lastly, about 35% of calls deemed eligible for Be Heard did not receive program services. So, like, you responded to the person in crisis, but you didn't connect. They didn't get anything. So, one of the things, though, that I do want to just point out really quickly about the overnight hours piece, and we were talking about perceived crisis before, and you're going to see this a little bit in this argument through IBO about that the calls during the nighttime were way lower, um, is actually that call volume is always going to be higher during rush hour because people are going to be perceived to be in crisis. Poverty is such an extreme crisis in this city that when people are going to work and they see someone who's unhoused and maybe talking to themselves or using substances, etc., they may think that that individual is in crisis when in reality that's their everyday, which doesn't take away from the severity of their life, but that is not a mental health crisis, right? Like, or like an active, like, state of psychosis, mania type of thing. That's not what this is exactly. So, the reason why I'm saying that is because there's this argument sometimes that we don't need Be Heard overnight because it's not, that's just like there's not enough calls. And it's like, well, who's calling and when are they calling, right? Is it people calling from themselves and saying, I'm in crisis, I need support? Or is it the person walking to the subway who sees someone muttering to themselves and, may feel uncomfortable, which is, valid and fair, but there's just layers to it, right? Like, and figuring out like how to best to use the resource. Um, Anyway, so mental health calls are assigned a low priority through FDNY's categorization, which is also why there's so few teams. Teams spend longer on site than other types of calls, which is actually good because that means that they're de-escalating and actually connecting people. And IBO's analysis also indicated that response times are slowing as the number of calls decrease, not just so PIC is the new term for it's person in crisis instead of like EDP. It's the same thing though. Um, and not just for calls eligible for Be Heard, but for like all kind of person in crisis calls citywide. Um, the and then I just have one chart from the IBO report. So this shows you all of the quarters, and then it shows you the total number of EDP calls, the calls eligible for Be Heard response, calls assigned to Be Heard team, calls that received a Be Heard response, and then the calls that did not receive a Be Heard response. And you can kind of see that some of the patterns stay pretty standard, but the point is that one of the things that you see consistently is that there is a need for more teams because there are enough calls where you would need more teams to be sent out, but calls automatically get a police response because there's just not enough teams to be sent out. Um, and this is again, like I said, in the PowerPoint that you guys have that you can go over in detail later. Um, so how do we create a better Be Heard? Well, these are some of the immediate changes that we think should happen. We need to mandate that peers be added to Be Heard teams. This could either replace the social worker or it be an addition to the social worker. This is something that we kind of there's pros and cons of both, right? Um, we need to expand the number of Be Heard teams to match the call volume. There's currently only 18 teams, as I said, which isn't enough. We have to expand the number of teams to ensure that it's citywide and 24/7. And you can also do that though with dynamic staffing. So just because you have maybe 18 teams during the day doesn't mean, or let's say if at right now it's 9 to 9, but like the point is like you wouldn't need to have as many teams overnight as you would during the day if that's the way that the data is trending. And then lastly, establish 988 for a number to, or well, use it as basically a triage system to for dispatch and sending calls. Um, I don't have specific asks for the community board and the committee right now because we are in such flux due to the new mayoral administration and the Office of Community Safety that we're kind of like, okay, this is what we want, right? We think we need to work with the administration to make it happen. And last year, we did a lot of advocacy to have $4.5 million added to this budget to get peers added to Be Heard. And basically, what happened was instead it got $4.5 million added to the speaker's budget to add peers to like community service programs, like places where I work and, places that aid in the continuum. But we realized that we don't think that the city, like doing city council budget advocacy, is the way to necessarily make some of these changes a reality. We do need the budget money to, staff the program and make it more robust, but we think that most of the changes need to be more administrative. So right now we're trying to pivot and try to figure out, okay, like what is the best way to get all of these things happening? Um, my one ask of you all would be there is my colleagues at New York Lawyers for the Public Interest are doing a survey with people who've received a Be Heard response, and we don't know anyone. We know so few people. So if you know anyone in, um, you know, anywhere who's had a Be Heard response, but especially in our community board or our community, please, we can get them connected. There's also, I believe, a small stipend for participating in the survey. Um, and it can be anonymous. But yeah, that's basically my overview.
Amparo.
Do you have promotional material for that question, that survey?
I
You should
think they're still
share it with.
developing it.
Oh, okay, because
I
please
can ask.
share it with us when you
Yeah.
do have it, because that's something that I feel that we could add to our newsletter.
Definitely. I will follow up with them tomorrow about it, and ask them to like develop like a QR code. And I know they were working on that, I
Yeah.
believe.
Thank you, Jordan.
Yeah.
No, I agree. That's what I was thinking too, Amparo. It's also something that we could put on the table at the or mention at the community board meeting itself too.
That's it. Any other
So
questions or
that sounds
anything?
great. Yeah.
Keep us posted on how we can further assist, though. We really appreciate it.
Yeah. No, definitely. I felt like I had uh I just had all these ideas before I was coming in that I was like, wait, I don't know what to do for my ask because like everything is in such flux right now that it's really hard. And I feel like, and not that I'm wasting a budget cycle, but we are doing the advocacy from that 4.5 million. We're trying to expand it to 6 million
Okay.
because the other thing is that this whole conversation about the Office of Community Safety or Department of Community Safety, we need more behavioral health workforce people who are trained and have lived experience who can connect. And we have to also do workforce development. So there, yeah, and I do appreciate that Julie Wan is the chair for the Workforce Development Committee, and I've been in talks with her to hopefully have a joint committee hearing with Tiffany Caban, who leads the committee for mental health, to have an oversight hearing about behavioral health workforce initiatives.
Okay. Sounds good. So I like the fact that your requests are, you're also focused on the administrative requests, which may actually be easier. Budget requests sometimes are, yeah, a little bit harder to get approved, but
I
that's not
was
to say you
really
got the 4.5 million, keep
I
working.
was so impressed by myself last year. It was like
Get
the
that.
biggest happy accident. I was like, wait, I did that? What?
Yeah, so you got precedent. So now you fight for the 6 million. So,
Thank you guys. I really
okay,
appreciate it. And you can always contact me via email, and I hope to still be around. I couldn't come to the meeting last week. I had a personal commitment, but
okay.
I hope to still be around. So,
I
yeah,
would love that, Jordan. Thank you. Thank you for always keeping us posted and being like willing to speak to, because it was like impromptu the last time you spoke up
don't
before
worry
our
about it.
committee meeting. So thank you.
Okay. Bye, everyone.
Okay. Bye, Jordan. Okay, Miss Charlene. Okay, now the next presentation will be on Birth by Queens. Hi, Charlene. Good to
So,
see you.
share
Hi,
to
good
share your
evening,
screen.
everyone. Am I okay to share the screen?
Um,
Yes.
Yes.
Put this on preference of view. I always tell people my messy habits is tabs. So that's my to-do list. So I'm not gonna hopefully burden you with all the tabs I have and just
No,
share
okay.
it
It's
appropriately.
okay.
I think it didn't work, so it's okay.
Okay.
That's gonna be part of my tab list. Um,
Okay.
can you see my screen okay?
Yes, we can.
So it is a pleasure to be here for the committee. I know we didn't have a lot of time during the community board meeting, but there was a wealth of interest based on what I presented. So for those who weren't there, my name is Charlene Mitchell and I'm representing Birth by Queens. And our goal is to develop the first birth center in Queens. Our motto is very strategic in that it's a place where birth is just the beginning because we really believe in the importance of creating a model of care that doesn't just speak to the gestational carrier, but really speaks to the family unit before it becomes a family and long after. So a little bit about what a birth center is. A birth center is a healthcare facility for childbirth where care is provided in a midwifery and wellness model of care. And this is particularly very important because a lot of people think that there is just one type of care provider, right? And the midwifery model of care is unique in that it really focuses on the physiological process of birth and that for the most part, birth is going to happen. It's a normal physiological process. So we're not going to focus too much on interventions. And interventions that are offered are non-medical interventions, more physiological and different types of maneuvers and support. As a freestanding birth center, that means that we are not a hospital. So if someone needs a C-section, we cannot provide a C-section. If there is a situation in which it's a normal course of labor and then something happens and that there's an emergency, the providers are trained to address emergencies and normal pregnancy outcomes, but we are not, people are not coming to us for extended level of care. A big part of the birth center model is also that it's person-centered. So if I was to walk in and you was to walk in, we're getting two different experiences because we're two different people. And that's really personable for a lot of people because sometimes when they walk into that hospital setting, they don't see people that look like them. Particularly in our neighborhood, 50% of families in Queens are foreign born. So they might not have someone that speaks their language. In the midwifery model of care, while we don't speak every language, we go the extra mile to make sure everyone feels welcome, whether that is connecting them with another community resource or making sure that we have that translation services available. We're also evidence-based. So in the age of social media, you might see lots of things on, yeah, you should do this because I've seen it on TikTok. And if I'm being honest with you guys, this is what our parents are doing in Long Island City. I've seen it on TikTok, so it must be true. And it sounds crazy, but more often than not, in my consultations as a doula and also as a lactation consultant, this is where they're really getting their information from. Even though they're going to see their care providers, this is their trusted source. It's community centered. Just like the community board, it is inviting of all the individuals who have a stake in it. And for us, we believe that that's everybody, whether you're a gestational partner or not. We also believe in providing resources. So sometimes we get in a situation where we encounter a pregnant family and maybe the need is not for the baby, maybe the need is for the household. Maybe it is that they don't have enough food. Maybe they don't have access to fresh food. Maybe they need access to a nutritionist. I had a case in which a family I supported got gestational diabetes and they put her on insulin. No meeting with a nutritionist, no concept of what could have changed in my actual scenario to help me address the actual need versus putting me on medication. I have families who I work with who are unhoused. I have families who are pregnant not for the first time. So sometimes we're talking about how can we make sure that this pregnancy is as healthy for you as it is for baby? And then how can we enroll that other child and make sure that they're signed up for summer rising or they have completed their high school applications? So we literally are a conception to college model. And this is by nature of the way in which I entered the work. So before this work, I was actually a school counselor in Brownsville, Brooklyn. So this is what I did from a day-to-day basis. And I believe that it was a reason in which I was given this particular student on my caseload. The student in 7th grade, she was repeating the 7th grade for the second time. She got pregnant. So this was one of the students that, you know, most teachers didn't really have a good handle on. So she would kind of be passed around. And for, if anybody is familiar with the school system and like the waste, the amount of waste that goes into breakfast and lunch that ends up being thrown in the trash at the end of the day, it's enormous. So she simply asked for a second lunch. She's pregnant. She's actually entitled to a second lunch, noticeably pregnant. And they said no. So because the student is like, you're going to tell me no, I'm going to show you. That ended up in my first ride in the EMS to EMT, and we had to take her to Brookdale for observation because she was pregnant. Thankfully, she was not, you know, injured. Baby was not injured. The body tracing was okay. And there wasn't much follow-up after that, but that all could have been avoided if in that moment there was person-centered care. In that moment, we realized that, yes, she's a student. Yes, she's hungry. She's a person. She's an individual, and is going to go in the trash. And we focus on a resource that we readily had available. That whole scenario could have been avoided. And then we have a whole hospital admission that didn't need to happen, that costs us money as taxpayers. So it is really a large cycle that is happening over and over and over with our families. And that's just one case. And that's a case that's before she even turns 18. So you can imagine how many other interactions she is going to have that is going to potentially cause another admission. Now let's look at what's happening for our families here in Queens. And this is the entire borough. The Department of Health, God bless their souls, they're always behind with their data. But generally, the numbers in terms of like our birth rate is typically around 24,000 in Queens. So that's all babies born in Queens throughout the entire borough. Of those babies born, there's about 65% of those babies that are born vaginally and about 36% of those babies that are born surgically. So a vaginal delivery compared to a C-section, vaginal delivery, usually the recovery time is a little bit quicker. The C-section, it is a surgical procedure. So that allows for, well, that requires more preparation, more postpartum support in many cases. And it is a major surgery. If you've never seen one, it's basically going through 8 layers of skin. 452 VBACs, and VBACs is short for vaginal birth after cesarean. And a vaginal birth is, in most cases, a safer option after a C-section than a repeat C-section. However, our families who are going for VBACs, they're given false information, and unfortunately, in some cases, they are having their rights taken away from them. If you're on social media, there is a very unfortunate story that's circulating. It's actually a true story, and that the client, the pregnant person, was advocating for a subsequent vaginal birth after a C-section, and the hospital took her to court. So they got a third person judge to decide what should happen with her body. Talk about autonomy. Talk about choice. Talk about patient privilege. A third person judge who have never seen her before is deciding the care that she should have for her pregnancy. And this is not just something that happens in other states. This happens right here in Queens, but it just doesn't make the news. In terms of the numbers, so what is happening in our hospital system? So we have about 8 hospital systems. If you are, maybe you are aware, maybe you're not aware, but I'll just reiterate that Mount Sinai Queens is here because they provide some prenatal support, but they no longer do labor and delivery. And nobody's talking about it. It's just like it was just taken away. And then, then it's just people in Queens just have to figure out. Long Island City just has to figure it out. And when you look at the numbers, and you might not see the exact numbers, but if you add up all of the hospitals together and look at Katz Women's Hospital, LIJ, they still outpace all of the babies from all of the other hospitals at this one hospital. More often than not, a lot of the families I serve end up delivering at LIJ, and it really could be night and day. Some people have great experiences. Other people, they're like, I can't believe I'm back here again. But in the best case scenario, you at least have a room. Because it's a very sought after hospital, some families don't even make it to a room. There was a recent news article and also follow-up story about a young lady. This was the second baby. Went to the bathroom, was asking for assistance, and she delivered the baby on the floor in the bathroom. A client that I specifically work with at LIJ, the birth was beautiful. She had everything that she wanted in the birth. Postpartum, I did like a follow-up call just to check on her. She's still in care. I was like, well, how did everything go tonight? She said, horrible. And I was just like, I called her immediately. I'm like, I sent her a text and then she said horrible. So I called her immediately. And she said that the nurses refused to come give her a bath. So imagine you just went through a very traumatic experience to bring a baby into the world. And your nurse who was assigned to you was refusing to give you a bath. And by bath is really strong exaggeration. Really, they're just wiping your body down. So imagine that level of care at a very vulnerable time. And there's stories upon stories upon stories upon stories about care, particularly for our families who are on Medicaid. And it's just very disheartening. We really have to do a better job in how we're caring for the families that we serve. And it's just unfortunately really hit or miss. And it's not just LIJ. I've seen similar experiences at other hospitals. But because they have so much volume, sometimes that's even an added barrier because they can't really serve all of the families that they are admitting. On the other section, you see like here, this was February of this year actually. So 588 586 babies born in February. They've already had more babies than St. John's Episcopal will probably have for the year.
So, so you said the Cats woman, this is the sought after hospital. Is
Yes.
that what it is? So people, what is it? They hear about the reputation and that's where they want to deliver?
Mm-hmm.
Okay.
Yes. I'm in a meeting. Thank you.
Okay. Little one.
And then we look at they have a high population of twins and triplets. A lot of families go there for that as well.
Okay.
So they have 11 sets of twins already.
And these are the numbers from what, just February, from February alone?
February alone. This is February alone. So from January to February.
Okay.
Yeah, so year to date. So now when was my last birth? I was there. I don't have my phone. I was there in last month, but I didn't take a picture. It probably wasn't updated yet.
Okay.
So now where do we go from here? So we know the need, we know what's happening with our families. How do we start to think about and conceptualize what this could be for Queens, and why is this important? So looking at the map of Queens, we had some support for some volunteer members who was assisting us with trying to conceptualize where the hospitals are and where like the public transportation lines are. So the numbers here are the represented hospitals that we just talked about. As you see, there's like a cluster here, and then this is LIJ Cats, the one that has the most. There's a nice big gap here. And then here is St. John's Episcopal, which they really don't pass 1,000. And then over here, this is where you guys are. And then the one is for Mount Sinai, who doesn't provide any maternity care and delivery. So there's tremendous capacity in terms of what can happen for a birth center, because it's something that is definitely needed, right? As we literally are sitting in Black Maternal Health Week, we're still talking about the same challenges and disparities. And the work into birth center care, I also have looked at the history. So the first maternity mortality report or disparity report was actually in the 1930s. The 1930s. And here we are in 2026. We have more technology. We have more advancements in so many things at this point. There are robots doing complete surgeries, but we can't figure out how to keep people alive. And what people are not realizing, while the statistics are one thing that people talk about, you're 4 times more likely or 8 times more likely, this does not account for the near misses. And a near miss is someone that was going to die, but they were able to recover them. And the other layer on top of this is that the deaths that are happening, the research shows, and this is investigated by the Maternity Task Force, is that many of these deaths are actually preventable. These are not deaths that we don't know what happened. When it is fully researched and investigated, these are preventable deaths. So my favorite quote that I say, and it's very popular, insanity is like repeating the same thing, but expecting better results. That's what I feel the healthcare system is and continues to be, because we continue to pour more money into the same solution that is not working, but we are expecting our families to get better. We're expecting birth outcomes to be better. We're expecting the number of deaths that we're seeing every year to decrease. But if we're doing the same thing over and over again, we're not going to see any change. And that's how I got into birth center care. So birth centers, in terms of what that looks like holistically, there are about 415 birth centers across the United States. There's 40 of that. There's birth centers in 43 states, including there's one in Puerto Rico. There are 9 now in New York State. So there was just one in Brooklyn. Now we have a second one that has opened in Brooklyn as well. Brooklyn gets a lot of resources, and many of even the family wellness suite, there's one in Brooklyn. So, that's kind of been the pioneer in terms of like birth center care but it has not transferred over the BQE. I don't know what it is. If they could just allow us to have a little bit of support on this side of the BQE, that would be wonderful, but it just hasn't happened. And I ask the question time and time again, when is it going to happen for Queens? And as we start and talk about development, while the 2 New York City birth centers exist in Brooklyn, there are conversations throughout the state about increasing more birth centers. So I'm not sure if you all follow other boroughs, but Vanessa Gibson, the borough president in the Bronx, also was working on a birth center called the Birthing Place. There is another birth center actually coming to Brooklyn called Haven Midwifery. There's a birth center coming to Long Island called One Love Midwifery. And the Gaia Midwives is working on one in Nassau County. One Love is in Suffolk County. So everyone is working towards addressing this as an idea and as a good solution to the maternal health crisis, but no one is talking about Queens.
Okay. So that would be potentially 3 in Brooklyn then, if it's this
Yes.
extra one. Okay, additional one. Okay.
Yes, that would be 3. And
Okay, and
the second one in Brooklyn maybe has been open for about 2 months.
Okay. What do you think the difference is in terms of the climate? Is it just politically, the political will is there, or what? What do you think is the issue in Brooklyn that they're able
That's a
to?
good question. So I think sometimes, well, the first birth center was sort of grandfathered in, so there was political support for it at the time. And it kind of went through, which was a very heavy process called the certificate of need process. Now the certificate of need process still exists here in New York State, and it is really the barrier between having more birth centers and not. The birth center that has been in development for, the third one that's coming to Brooklyn, they have been in development for quite some time. And that is due to the certificate of need laws, which requires us to basically go through a process as if we're a hospital. And if we go back to what we talked about before, we're only addressing care that is low intervention, which that sounds like, well, who are the people and who are you going to be serving? 90% of families have uncomplicated pregnancies. It's the 10% that we hear about on the news. So we're serving a large amount of people potentially, but it just doesn't make sense. It doesn't add up. And I actually had a conversation with one of the families from Long Island City, actually CB2, and I asked her about her birth experience and how it was, and she said it was a wonderful experience, but I was in labor and I took the ferry to my birth. So imagine, what if your labor progressed very quickly, and then you had your baby on the ferry, and that's just one person. That's literally the easiest way to get to Manhattan, to the next hospital. And it's scary, really, when you think about it. It's really scary. So what does this mean for us? So looking at the disparities, how much success there is with birth centers across the world, 415. And I've seen also outside of the United States, I've seen the one in Toronto as well as in Iceland. Incredible. I got connected to one of the particular birth centers that really stands out and really like helps my heartbeat an extra beat sometimes, called Birth Detroit. And if you know anything about Detroit, Detroit is a community that might be looked at as a place in which doesn't have as many resources. So I would equate that to our NYCHA system. So I grew up in Queensbridge houses, and we had a large plot of land. We have the largest public housing facility throughout the United States, 96 buildings. Detroit thought about this land, and this is the piece of land that they looked at, vacant land, disregarded. No one was thinking about anything, but this group of people came together and said, you know what? We're going to make a change in our community, and we're going to develop a birth center. So this little one that keeps interrupting me, this is her right here, 2 years ago. Look how tiny she is. And we had the opportunity to see Birth Detroit before it opened. So when it was an idea, this was actually like their showing, like this is not like the staging, that's what it's called. This is actually their staging before they opened it up to the community. And to see that people can come together and do hard things, and envision better for their communities as long as they work together, is something that's absolutely possible. So Birth Detroit now is in a year plus of existence, and they're seeing clients regularly, and they have really been a great resource for the community, and they really keep me inspired. So when I have like a difficult day, or I'm just like, wow, this is a really hard process, and I'm like, am I sure I want to do this? I actually keep a pebble from their opening with me, to keep me motivated on the journey, because sometimes it can be a little bit isolating, especially when it's something that hasn't happened yet. But I tell people, if they can turn a gas station into a Starbucks, there's no reason why we can't turn a building into a birth center right here in Queens. And here's our ask. So let's build together. So conversation is an amazing thing. I'm very grateful that we had the opportunity to present before the community board, and there seems to be great interest with it. But the next steps for us, and in terms of like how we can really help to move this forward, is the formal letter of support from the community board. And I think it's also important to not only say like, this is something that we want to do as a community board, we also want our elected officials to be on top of this and know that this is something that we think is important for the work that we're doing. I know the community board can take up a lot of your time, but if there's anyone that has additional time in their day to support the work that we're doing, we have a lot of like great projects, going from community-based play dates. There was like one of the groups that was like, well, we have all of these ice cream cups and things for an ice cream party. I'm like, let's just have a community ice cream party. And they're like, I didn't think about that. So I'm the idea person. I'm like, I see the resources and I just connected. I like, let's have a community ice cream party. During spring break, we held a community play date, and then spring break was coming up the next week. And then someone was like, can you guys do this again? And I'm like, yeah, sure, we can do it again. Like whenever there's capacity for us to do work and expand the work that we're doing, we're always happy to do so. We do one of my daughter's actually favorite, because she loves to read. One of my favorite programs as well is the Book Buddies program, in which we read in the New York City parks. So we take an hour on the first Saturday of the month, and we read to the kids. And it's not like your average reading where we're just like going page by page. We really make it interactive and engaging, and the kids really enjoy it. The parents enjoy it. And it not only helps to support social emotional learning, but guess what? It helps community members meet each other. And that is important, because when you are either the first person pregnant or the last person pregnant, everybody forgets or no one knows anything. So to see other pregnant people in community is also helpful to also develop that community village in which we used to have, that we have to work on bringing back. And we're also present across social media, Instagram, Facebook. We're working on our Twitter. We have one, and we've been told we need to be on TikTok, but that is not our mission just yet. But we really are really excited about this project. I think based on the interest that I heard also at CB2, I think it will be strategic for us to continue to work together, because ultimately we want the same thing, right? It might not, the things that you might have asked for might not been called a birth center, but the capacity for what a birth center can do really runs the gamut of all of the residents, from the people who aren't born yet to the people who are 80 plus. We have programs in which we are working on documenting birth stories. And this is a really important part to me, because some of the hospitals, as I was doing my research, no longer exist. They no longer exist. And I asked when I'm doing a presentation, like, well, I had my baby at this hospital. I was like, well, I never heard about that hospital before, because it doesn't exist anymore. But that person is living. That person matters. Your story matters. So we're working with the Queens Public Library, Queens Connect, to help us document and archive these birth stories, which is going to be phenomenal when we can get more volunteers and really have people like just listen to it. And our next spinoff would be to get the voices of the partners too, because I often feel as a doula, we have partners that are present. We have a lot of partners that are present, and sometimes the provider doesn't even look at them. And there's not enough support or research on what their experience is like in pregnancy and postpartum. And you had a presentation about mental health, but nobody is looking at that partner going through mental health crisis. And that contributes to the numbers that are presented for Be Heard. So I can talk about this forever. So I'll stop for questions because I know I can go on and on.
Okay. Amparo.
Quick question. Can you mention your first, your 1,000 Days campaign, please?
Oh, yes, absolutely. So we are on 1,000 Days campaign to open the birth center, which lands us around December 2027. And it is fingers crossed. So if 2027 is our goal and it happens the way it's supposed to happen, like all of the birth centers kind of have a similar timeline. So potentially this could be 3 birth centers that come to New York City if everything works the way it's supposed to.
Okay.
Yeah, so today is actually day 194. I didn't get a chance to post yet because I had to assist with a pickup today. That's why I was running a few minutes late.
So we expect us to make it to the post, right?
Yeah. Say it again?
I said I expect us to make it to the post then. We're not 194 then. Or
Yeah,
what?
we
No,
got
you're
it.
gonna be 195.
There
We're
we
gonna be
go. There
tomorrow.
we go.
Okay.
With your permission, if that's okay with
Sure,
you.
sure. Let's
Okay.
go. Let's
Okay,
go.
so let me I'm gonna do a screen grab.
Okay.
Everybody's ready. Sophia
Yeah.
Michelle, stay. Do not move. Move out the way, please.
Okay.
She's like, yeah, we're taking a picture. All right, let's get this done.
Okay.
All right, got it.
Okay.
So she's very familiar. So on Wednesdays, I do a virtual support group. And just like we build community in our events, we build community in our postpartum support group. So she thinks that's what's happening right now. And they, oh my gosh, it's like, your birthday's coming up, happy birthday. So in the midst of us discussing like the things we need to discuss, they're like, but I want to talk to my friend. So it's really grown. But the downside to the postpartum group, and I say downside because it has tremendous capacity for growth, but I see people from all over the country. And when I think about how many families from Queens are actually participating in the support group, it's less than 10. And when I look at Texas, I get people Texas, Florida, Arizona, Ohio, and I don't know, like the algorithms, like where the algorithm is going. But we don't get as many families locally in Queens. We get a lot of people from the Bronx, also from Brooklyn. There's one mom that she's almost due. Aminata, she's gonna be due any minute, like probably in the next 4 weeks, from the Bronx. She comes on every week. And I think once families come to us, they really stay with us. We have a Friendsgiving every year and someone always gets pregnant. So we always keep that continuity of care going some way. Maybe it's in the food. And what questions do we have?
Food brings people together though, so I could see that. And it's like you really are creating this community. I just wondered in terms of when you said with the not getting as many people locally for the postpartum support group, how do people find out about it anyway? Like
So usually I have 2 things. I have like a mailing list where people can get the mailing list, and then social media I always post it as well. We do like a calendar of events the first day of each month.
okay.
And can you speak a little bit about your community needs assessment that you're trying to get information?
Sure. So the community needs assessment is an important part of the work that we're doing, because in the certificate of need process, it essentially requires us to prove that this is something that we need. While we know the numbers, we know the statistics, we know what's happening directly in our communities, and we see it sometimes on the news. We have to prove that this is something that not only I myself is interested in, that the community board is interested in, but the residents of Queens are also interested in bringing this forward. And it also helps to elevate what else is missing in a conversation, so individuals can complete it. It does take like 20 to 30 minutes. I'm trying to figure out the best way to kind of get it done. If I can do like a grand rounds, I don't know if that can happen during a community board meeting. If there's like a day where there's not as much happening. But we really want to get the voices from each of the community boards, because many of the people on the community board also are families. So we want to make sure that we capture that information if they're not able to come to an event or things like that, where we're having a outreach kind of like situation.
I'm wondering if community engagement could help us with some of this in terms of getting something circulated, or what do you think, Amparo?
I think we should at least add the QR code to the newsletter.
Okay.
Yeah.
And I guess we could discuss here that we are going to be preparing that letter of support. So that is
Oh, yes, we were working on it.
working on it.
Yeah, yeah. What I had a question for you in terms of it, because should it be then directed to our electeds though? Because I wanted to say, I know it's like it starts out with the to whom it may concern. Usually our letters have like a particular official or agency that we're directing it to, and then we'll CC a bunch of other electeds. Should we be doing that? Is there particular
Yeah, you
like
can do it that
okay.
way too. So it's to whom it can concern, because
Okay.
the challenge is that the leadership in the health department always shifts.
Okay, so
So
then that's okay. So
that's
to
the
whom?
challenge.
Okay, so to whom it may
Especially with
concern.
the cutbacks, and you don't know
Okay,
if you have a job. So
okay,
that's why it's to whom it, but definitely feel free to CC the elected officials. That's what the other community boards did. I think there's like one form letter where you have your information, on the other side is like CC to all
Yeah,
of the
I
elected
I
officials.
think we have it in that format right now, Lauren. So
Yeah,
okay. All right.
that's perfect, and that's even
Okay.
wonderful. And if there's anything else that you have like questions about, and also let me know what needs that do you have, or if there's, and another thing is that I didn't put it here, but if there's a location that you like, oh, I think this location will be great, or
Okay.
this location is underutilized. Like when I tell you, we literally are looking at the sky, because ultimately what is happening here in New York, people are getting frustrated. I've even talked to people who before me was thinking about a birth center, and they're like, well, it's never going to happen. I was like, okay, thank you. We're going to make this happen. There's talent I met this woman from Syracuse, and I ended up in Ohio, no, not Ohio, Utah. I ended up in Utah, and she's like, yeah, you can come by. And then as we're in conversation, she's like, I'm from Syracuse, and I would have wanted to open a birth center in New York, but the regulations are just like, it's so cost prohibitive. So she literally moved to Utah, opened her birth center, and it's beautiful. Beautiful. And our families can have this here. They really can. And if you look at other things that are happening, like I don't know if you follow the rise in like these postpartum suites that are popping up everywhere. It's the birth that is the most important, where you need these opportunities. Do I think there's basis for postpartum retreats and things like that? Absolutely. But you have to get to that point.
Mm-hmm.
And a lot of our families aren't making it through.
Yeah. But I like what you said in terms of Birth Detroit being serving as an inspiration. If it could happen there, it can happen here. And I like your attitude in terms of saying that, like the can-do attitude that you have about it,
Yeah, I'm
Charlie.
like, these people. I'm like, I reached out to you for motivation. You're like,
No,
we
no,
tried. It
no, we
didn't
try.
happen. I'm
No,
like,
no,
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 that's
no.
not what I need to hear. And depending on how much time you have, the Maternity Center Association was the first model for the AABC, which is the overall 415 birth centers, and that started in Manhattan.
Mm-hmm.
And it started as a project in 1917, in which the commissioner at that time said, we have to investigate this maternity mortality crisis. And they started with the development of birth centers. Well,
Mm-hmm.
they called them maternity care centers. And
Okay.
then a couple of birth centers actually opened, one of which was in the Bronx, Morris Heights. The last time I think they were open was 2010. So, there's precedent for this. It existed. It exists in Brooklyn. Um, so it's definitely something that can happen here in Queens, but I think it has to be collective action. People have to know what a birth center is to know that this
Mm-hmm.
is something that
Mm-hmm.
they want. Because a lot of people are saying, I want self-directed support. I want to be surrounded by my family. And those are things that are open at birth centers. You can't bring like a football team, but we definitely can accommodate mom, dad, grandpa, and siblings. Like
Mm-hmm.
that's the other crisis I see as a doula in the hospital setting when there is a subsequent sibling, and I'm just like, we have to plan around who's going to care for
Yeah.
this child, and you barely have enough support for yourself. So
Mm-hmm.
it's really hard when they can't be a part of the process. Midwifery
Right.
care, they'll have the sibling like cutting a cord. Like, it's like everybody's involved. It's
Mm-hmm.
education for everyone.
Mm-hmm. I remember reading an article recently where somebody like they were trying to kick the doulas out of the hospital. The person was in
Oh
the
yeah,
hospital or something, and it's just like, okay, thank you. And
yeah.
they had like called the security to escort them out and stuff. Yeah.
That sounds about right.
Mm-hmm.
That hasn't happened to me. There
Mm-hmm.
has been a situation in which, it was a very difficult birth. And we're kind of still processing through that birth. It wasn't in Queens, thankfully. But I will say in that scenario, I'm very grateful that that parent made it through because that parent on went in and said, something's not right. Went to the hospital and she was just sitting there. She was just sitting there for several hours. When I got there, they were taking her into surgery. As we're sitting there, the hospital, I'm not hearing any information. I'm not hearing. It doesn't take a long time for these
Mm-hmm.
babies to be born when it's a C-section. Really, it takes like 10 minutes, to be
Mm-hmm.
honest with you.
Mm-hmm.
The rest is the sterilization and cleaning up and closing up.
Mm-hmm.
So when I'm not hearing, in some hospitals they have a specific bell that they play, and I'm not hearing, but I'm
Mm-hmm.
hearing code stat multiple times.
Mm-hmm.
When I'm looking at the partner who doesn't speak English as a primary language, and they're telling the partner that everything is fine, it's really shameful.
Mm-hmm.
To add the icing on the cake, they put the client into a situation where she had to go into ICU, and then grandma was there, and they basically kicked the grandma out. They kicked the grandma out, and they told her, I was there for this. They said, this is not a hotel. This is not a hotel. You cannot stay here. It was definitely a hard birth, for sure. But thankfully,
Yeah.
baby's doing okay, mommy's doing okay.
Yeah.
But you don't heal from that.
No, it's traumatizing, is what it is. Traumatizing.
You don't heal from that, and
Yeah.
it's not gonna show up on the maternity mortality numbers. But she's again one of those near misses that I talk about.
Mm-hmm. Mm-hmm. Yeah. Well, anything that we can do, we're happy to support. And I also like the idea, you said that you post the calendar of events um on a monthly or in the beginning of the month, right? Because that's the other
Yeah,
thing. I'm thinking like another way to get like, people really tuned into the cause and everything else is by
yeah,
attending some of these community events, like the book buddies and whatnot.
yeah.
So,
And if there's a location that you guys recommend
hmm
that I go to, I try to like go by way of New York City parks.
okay.
And hopefully we're gonna expand it so that we have like a free London library at a couple of different parks throughout Queens.
Hmm.
We also have the Bottles for Birth Center campaign. If you guys are water bottle drinkers or cans or bottles, the Bottles for Birth Sensors campaign, basically, literally, you're collecting your recyclable bottles and then you're turning it into a maternal health chain. So you can essentially, you collect 200 bottles, you go on the app, you request pickup, and that's it.
Okay.
So most recently, we had someone donate about 1,100 bottles.
Okay.
They like got together like a group of them, so that was like really exciting.
Okay.
But I think that is something that really can be implemented at all of the events. Like there's so many events that come up throughout the community board that I'm like, oh my God, I wish that there was just a collection for all of these bottles that are on the street, that everyone's just throwing away. So if that's something that the community board can be assisting with, um, hey, the elected officials having this event coming up. Can we collect those bottles from your event? Because the bottles are already there.
Mm-hmm.
They just ended up in the trash.
Mm-hmm. Excellent. And just when you talk about site select, is there any like the parameters like for selecting a site? Like, is there any like something that you're looking for?
Yeah, so basically the first parameter is that it has to be within 60 minutes of a hospital, but because we have so many hospitals, that's every neighborhood in Queens. Like I went very like anally through this and made sure that everything crossed. So every neighborhood is within 60 minutes of a hospital. So that's a big
Okay.
check for us. That's not
Okay.
so for many of our rural hospitals and sisters. So the next thing is making sure that we can get it zoned for medical use. That one I'm not sure on the actual zoning language.
Mm-hmm.
Usually it has to be a commercial space, but in some cases it has to be zoned specifically for medical. In other cases it can just be commercial space. For us, we would like to start with a facility that's at least 2,000 square feet, just because we are not just providing the birth. Our goal is to have at least 3 birth suites in which we can serve 3 families at a time.
Mm-hmm.
And the other thing I didn't mention, I didn't know if I mentioned it during the presentation, is that the birth process is, after you are stable and baby is stable, you go home. It's not, we're not holding you hostage. That's the other thing that I love about birth centers. It's just like I can just go home, and eat our brother's food. Like, yeah, let's go home. I don't want to be
Mm-hmm.
here anymore.
Mm-hmm.
My work is done. So yeah, that's the other thing. So usually families are with us at most 24 hours after delivery, then they're going home. Is there anything that's like top of mind in terms of like locations in CB2 that you think we should look at?
Not offhand. I was wondering that how we inviting land use committee into this too. That's what I'm wondering, since we're talking about site selections.
I'd want this to be a part of the Sunnyside Yards project. Whenever that would happen.
Listen, I mean, we're open to, and that this is the other thing, right? I
Mm-hmm.
feel like if we can have 8 hospital systems, we can have more than one birth center.
Brooklyn's getting 3.
They're about to have 3. Like we got to catch up. we got to do double time. So like Long Island City project rezoning, I testified for that. So I'm gonna
Mm-hmm.
make sure. My goal is to, if I being honest, like I want this to happen as soon as possible,
Okay.
because the downside of that happening, that means that there's more maternal deaths.
Mm-hmm.
Like this is like a crisis, even though people are not talking about it as a crisis. It really is a crisis. So sometimes you have to make adjustments based on like what is available, and that's a very real conversation. So I like to be open and honest about that. But Long Island City is very important to me, and that's where I grew up. That's home for me, right? So when we're looking at priorities, I think Long Island City is a strategic place to put a birth center, but we also know how expensive Long Island City can be, how low the inventory of space could be. So we're also looking at that and like saying like, okay, is this realistic for us right now? But as we look at different projects, we looked at the LIC rezoning. We definitely testified during that. The Sunnyside project coming up, we would definitely be happy to testify for that. we think that there is tremendous capacity for there to be more than one. And our goal is to make sure that it's accessible to as many people. That's the other thing, right? So when we open, we want to have some form of accessibility, whether that's a bus line or a train line.
That's true too. That's the
railroad.
other thing. Yeah, accessible.
Yeah. But
You need
also
that.
another thing that a lot of families don't know is that Medicaid covers transportation services to medical appointments.
Okay. That's important. That is, yeah. So can add that to parameters in terms of it, like accessible.
Yes.
Accessible.
And I might have to make sure that there's a city bike station nearby, because you guys are going on about that city bike. City bikes are important in CB2.
Yeah.
So we might have to petition the city for a city bike.
Okay. All right.
Location.
All right. Okay.
My client that I mentioned about that comes to the support group,
Mm-hmm.
she rides the city bike every day. Like, she's
Okay.
32 weeks pregnant.
Okay. The support group is hybrid then, because you have people.
Yeah, it's
So you have
virtual.
people. It's virtual.
Yeah, it's
Okay.
virtual.
Okay.
Yeah. We had some that was in person. Actually, we had one at Tribeca Pediatrics, and there wasn't like good attendance.
There wasn't good attendance, you said?
No.
Oh, okay.
So I
Yeah.
would go and nobody would come. So
Okay. Now virtual is easy. It takes care of a lot, even especially if you're taking care of children and stuff like that. It's just easier.
And I'm definitely open to revisiting the conversation with them and see if that's something that we can revisit. But they, like, from their standpoint, like, they're keeping the building open, for another 2 hours or whatever the time that it takes. So for them, they're like, it's a waste. For me, I'm like, we tried. I'll keep coming until we get more
Okay.
people. But for them, it's like, we got to pay the lights. So I
Okay.
get it.
All right. Okay. No, it's fine. It's fine. You're getting people. But how many people then do you think attend your, just as a general matter, the postpartum support groups? I know they're from different areas, but how many do you think attend?
So I would say between prenatal, every week, maybe between 10 and 15,
Okay.
between a prenatal and postpartum group.
Okay.
Yeah. And we have people who attend that are like frequent, we call them frequent flyers. And then we have people that are like one-offs, like they'll come and say, I'm gonna deliver it tomorrow. Can you help me? And that's
Okay.
more common than you think. I had someone call me today. I'm looking for a doula. I'm like, okay, when do you do? Tomorrow? I'm like, that's gonna be a little hard. But I give you a quick prep
Okay.
as much as I can. But
Okay.
with this Medicaid
Okay.
doula benefit, if there's something that you can put in a newsletter about that, that would be great too.
Okay.
Because the Medicaid doula benefit has been around since, I want to say, March or April 2024. Families still don't know about it. So they're literally finding out the week before they're due. And then, I don't have any availability, or even any of the other doulas don't have availability
Okay.
to support them.
Interesting. You said since March 2024 it's been around.
Yeah.
Okay. Interesting. Yeah.
And it's free, and it goes up until, if the client has delivered, and I can make it like a flyer for this as well to include in the newsletter.
Yeah.
If the client has already delivered, they get the postpartum visits, which is up until the child is 1 year old.
Oh, wow. Okay.
Yeah. So all is not lost if they already delivered. They can still have access to the postpartum visits up until the child is 1.
Things you don't hear about, I guess. I don't know. So I'm thinking it's like, wow, okay.
And
Wow.
it's
Okay.
free. That's why you don't hear about it. They don't want
That's
to pay
why.
for
That's
it.
that's
The
that's
less
why,
people
right?
that use it, the less you gotta pay, I guess. I don't know.
That's right. That's how the world works. It is. That's, or at least that's
Yeah.
how this system works. Yeah.
But I can say for me, like, when I'm working with families, like, it really is a holistic approach. So if there are other needs that the family has, like, I do my best to address those things. And that's
Okay.
how we kind of like fill in the
Okay.
gaps, because we know there are a lot of those.
Okay.
Yeah.
Wow. Okay. I don't think I have anything else. I'm just thinking about things, I mean, information, and I think you should feel free to, it's like, whatever information you want us to put into, ask to have put into the newsletter.
Okay.
And I agree with Baro about the QR code so that people have access to this information. And we'll finalize this letter of support and make sure that we get that to you ASAP. Okay.
All right. Sounds like a plan.
You know. But Charlene, I'm grateful. I'm grateful for the work that you do. I have a lot of
Thank you so
respect
much.
for it too. And thank you for your helping families and then babies coming into the world. So
And thank you for your interest, because it could very, very well be another priority that we look at a later time.
yeah,
So I
no,
appreciate you guys understanding how important it is. I know there's a lot of things going on right now, but if we're not looking at the future of CB2, then we're really doing ourselves a disservice.
no, absolutely. Absolutely. Um, okay. So feel free to you're always welcome back and to keep us posted on what's happening, especially as we're getting closer to the 1,000-day deadline. But and in terms of what we can do to help with the needs assessment and everything else like that. So it's just, yeah, however we can be of help.
Of course. I'm gonna stop this share.
And then this was live stream, so we should definitely, put this in the newsletter. Ask to have this put in the newsletter too, the link, so that people can watch, especially since there was so much interest at the full
Mm-hmm.
board meeting,
For sure.
you know? But thank you. We'll be in touch, Charlene.
Did you have any
You.
questions? I forgot your name.
Who? Mine or
Me, I'm Amparo.
No, I know your name, Amparo, at this
which
time.
name? Lauren? Which name?
All right. It just says CB2.
Oh, Raphael?
Me?
Oh,
I'm
Raphael.
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 Oh,
Yeah.
Raphael.
Yeah.
Oh. Oh.
I'm Raphael.
Nice to meet you, Raphael. Did you have any questions?
Likewise. Yes, actually. Would it be possible for you to share the presentation with us so that we can share it with our minutes so our community board members could take a look at it?
Yeah, of course. Absolutely. For
Awesome.
sure.
Thanks so much.
And
I
I'll
put
just
the email in the chat.
perfect.
Okay.
I see a future board leader. I don't know, guys.
Hmm? With who, Raphael?
Both of you guys.
Oh, would you see a future what?
A future board leader.
Oh.
Succession is a thing. I did 2 terms, so leadership
Oh,
changes. In one of
okay.
my presentations, it was the last for one board leader, and then it transitioned over to another one. So I'll probably go back to them again.
Oh yeah. Oh, which board were you on?
I think that was. Oh, which one was I on, or which
Yeah.
one am I talking about?
Which one? Yeah, which one were you
I
on?
was on CB12 because after I moved.
Oh, okay.
Yeah, with Reverend Thorpe's.
Oh, okay.
Yeah.
Okay. And so are you thinking about joining which one at some point?
Oh no, I can't join again because I did two
Okay.
terms.
Oh, you did two.
I think that you can
Okay.
only do two.
No, is
Or
it?
am I
I think
mistaken?
it's 8 years total, right? So it's four.
Oh, you can do
Four.
8 now?
Yeah, you could do it's eight. Yeah, it's 4 2-year terms, and then you have to then you're termed out, and then you can rejoin or reapply after taking a year off. So
Yeah, that's
you had
great.
Oh, I didn't.
so I don't know. We see a future. We see you returning to the
I didn't
community
know that
board.
loophole. You can take a year off and then reapply. I didn't know
Yeah.
that.
So
Amazing. So I will send that over shortly.
okay.
Thank you so much for your time and for
Thank you,
your
Charlene.
again your support.
Thanks so much.
Okay.
All right. Have a great night.
Okay.
Bye.
You too.
Bye.
Okay. Old business, right? Okay. I know that letter is outstanding. Working on it this week. Gonna do my taxes and
Yeah.
work on that letter.
Two letters. That's the old business,
Two
right?
letters. That's the old business. 2 letters. I'm gonna get like the federal deadlines out of the way, and then I will refocus.
Yeah.
Yeah.
I did have a question though.
Sure.
Raphael, when do people get their committee assignment?
I'm not sure, but I can follow up with Anatole.
Great,
Okay.
because I was just wondering who we're gonna get.
Sure
Yeah,
thing.
that would.
Yeah.
Yeah.
No,
Hmm?
every like agenda that we distribute, I send it out to the entire board members so everyone's aware of the meetings.
Okay, and I know that at some point, I mean, when is the when is the swearing in? I forgot what date they
The
gave for.
20th, I believe.
Okay. And
It's
then
on
at some
Monday.
point then they meet. But I know also they start like sometimes they will the new members will join committee meetings just to get a taste of what's happening. So
Yeah, we've had a few committee members already attending meetings.
okay.
Mhm. But I'll
All right.
definitely follow up with Anatole on that.
Okay. All right. Any new business? I know
Oh,
we've been
I did
oh,
want to mention, I
go
don't know if
ahead.
this actually matters, but tomorrow, uh, Borough President Richards is having a blood drive. I know we got that email and I wanted to make sure other folks knew about it. It's from 12 to 6 at Borough Hall. And we did have a presentation before with the New York Blood Center. So
Okay,
anytime there's any kind of, you know, blood
okay.
drives, either in our district or, big
No.
ones, I just want to
Mm-hmm.
make people know.
Okay. All right. So that was sent out to the board members. Okay, good. Oh yeah, thank you for pointing that out. Yeah, because we didn't we ours got our Sunnyside one got canceled, right? Because of a blizzard, one of our blizzards, right?
Yes,
Or
it was
whatever.
the blizzard. It was at a church, and yeah, unfortunately.
Yeah, so that was that. And then and thank you, Raphael, for all these emails that you've been sending us and just the flurry of like information. Um
Yeah, you're welcome. Sometimes I worry that I'm spamming too much, but I'm glad
no,
you.
no, it's like, people are very active. That's what it just tells me in the community, in terms of the things that are going on.
Awesome.
Um,
Yep.
I don't, do we want to share that? Because I know we get sent it. Should we be sending it to all the, well, I guess I don't know who our committee members right now are. I guess we're in transition right now. I'm Pato. So I don't
Yeah,
know.
and once we do have like our list, I believe sharing it makes perfect
Yeah.
sense.
Yeah. Okay. So anything else? New business, or you want to do the motion and
Motion
I
to adjourn.
and I second.
Thank you for this. Thank
Okay,
you,
you're welcome.
Raphael.
Thank you, Rafa.